Great. Well, we might make a start. We've got quite a bit to cover this afternoon. Before we begin, I'd like to acknowledge that I'm presenting this webinar from the lands of the Yorta Yorta people. I also acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this session. I pay my respects to elders past, present and emerging. Thank you for registering to attend today's webinar, or to those who may be watching the recorded webinar at a time that suits. This webinar has been developed for operators, drivers, and other industry members who are wanting to understand this project in more detail. My name is Josie Thomas, and I'm the Project Manager at the National Transport Commission for the Improving Screening of Commercial Vehicle Drivers project. I'm also joined by Michael McCarthy, our Strategic Engagement Advisor, Liam McElveen, our Policy and Project Officer, and Fiona Langren from Project Health, who's our consultant, who has extensive history in providing advice on assessing fitness to drive. It looks like we've had a really great turnout from truck and bus operators, regulators, driver licensing authorities, and other industry members. Here's an overview of the structure for today's webinar. Fiona and I will co-present on the following topics and then open to questions. The structure does resemble the outline of the discussion paper, but of course we don't have enough time today to go into all the detail. So we recommend going back to the discussion paper if you'd like to read up on some more material. The discussion paper isn't a literature review, but does paint a picture of the health issues in the industry, outlines the legislative and policy frameworks and other initiatives, and seeks your expertise in understanding how possible solutions might work in reality. We don't have enough time today to go into lengthy discussions, but we can meet with you outside of this to discuss things in more detail. Please add any questions to the chat if anything comes to mind during the presentation, and we can address these at the end. Firstly, some important project background and context. In 2022, Transport Ministers asked the NTC to identify options to improve the approach to screening and diagnosis of sleep apnea, diabetes, and cardiac risk in heavy vehicle drivers. The catalyst for this request was an ACT Chief Coroner's finding relating to the death of a 4-year-old child involving a heavy vehicle driver with undiagnosed sleep apnea. We released a discussion paper in March and are consulting on possible options until Friday, the 9th of May. We've included a terminology section in the paper to describe that while the IDEM request relates specifically to heavy vehicle drivers, a range of other commercial vehicle drivers experience similar health-related issues and are managed within the current systems, including licensing and accreditation. These include public passenger vehicle drivers, such as buses, taxis, rideshare, dangerous good vehicle drivers, and driving instructors. The scope of the project includes commercial vehicle drivers that apply the commercial vehicle standards in AFTD, and we want to test this during consultation. From the outset, I want to clarify that any changes to the screening criteria will be applied by licensing and accreditation schemes within their current frameworks. This means that if drivers aren't currently required to have a health assessment, this won't change. We'll discuss these options in more detail at the end of the presentation, but I thought I'd flag here the 3 options just to keep in mind as we go through the content. So the options represent a graded approach ranging from option A of no change to option B, improving implementation of current AFTD guidance, to option 3, which prescribes screening and includes 3 sub-options for each of the 3 areas. We won't be recommending regulatory change to driver licensing regulations around timing and frequency of health assessments. We'll be improving screening for those who are currently assessed periodically for licensing purposes, for example, in the ACT, and for accreditation purposes. This project focuses on screening and the management of drivers found at risk. It will not be looking at developing or revising the guidelines for how medical conditions are managed once they're diagnosed. This will be considered as part of the next review of AFTD. Here's a timeline with our 5-phased approach. We're currently in phase 4, involving 8 weeks of public consultation. We'll submit recommendations to ministers in the middle of the year. There's currently no date locked in for the ministerial meeting due to the upcoming federal election. The project objectives include investigating the current state of the issues, formulating evidence-based options in consultation with stakeholders, undertaking extensive stakeholder consultation to establish recommendations, which we're doing now. This diagram shows our key stakeholders. We have a heavy vehicle health advisory group, which includes government agencies, driver licensing authorities, the heavy vehicle industry, heavy vehicle regulator, commercial vehicle industry and regulators, unions and medical professionals. We've also established 3 working groups on sleep disorders, cardiovascular conditions and diabetes, and have medical professionals and specialists from the Cardiac Society, Heart Foundation, Diabetes Society, Diabetes Australia, Australasian Sleep Association, and the Institute for Breathing and Sleep. We've convened these groups once last year and have been in touch regularly via phone and email to consult on the content in the discussion paper. These working groups are medical technical groups, and their recommendations have been fed back to the broader advisory group and incorporated into the discussion paper. This slide shows our consultation plan. The blue shows the activities we've undertaken, and the yellow shows our future activities. Over the next 5 weeks, we'll be hosting webinars such as this, one-on-one online meetings, and face-to-face sessions with impacted stakeholders. We'll also be running a workshop session at the ATA conference at the end of the month. I also understand the commercial vehicle industry, such as the Bus Industry Confederation, may be hosting separate roundtables to consolidate the views of their members. If you have a peak body or a union group, please reach out to them to ensure that your views are captured in these discussions. We've developed a comprehensive communications and engagement plan and worked in partnership with stakeholders to identify channels to get the key messages out to industry. We're really keen to understand the views from a policy, operational and medical perspective and discuss how these changes might impact your organisation, stakeholders or members. Before, what is important to highlight or AFTD is. AFTD sets out medical criteria for driver licensing decisions in Australia and provides guidance regarding how drivers with various conditions should be assessed and managed. It includes criteria for both private drivers and commercial vehicle drivers. The focus of this project is on the commercial vehicle drivers, and the diagram shows all the different licence classes and which standard applies. The commercial standards apply to drivers of medium rigid vehicles and above. In addition to licensing, AFTD is also used for heavy vehicle accreditation programs and accreditation of public passenger vehicle drivers, dangerous goods drivers, and driving instructors. The NTC reviews AFTD every 3 years, and Austroads supports the implementation of the standards in collaboration with licensing authorities and other stakeholders. The next review of AFTD is due to commence later this year once we wrap up this commercial vehicle project. The role of AFTD in managing fitness to drive is complex. While it's being developed as a licensing standard, it's also applied across the transport industry for accreditation of particular drivers and also for fitness for duty. This diagram illustrates the complex relationship of licensing regulation at the top, other accreditation schemes at the bottom, and how they relate to AFTD on the side. In addition, while AFTD outlines the medical criteria to guide decision-making about licensing for people with medical conditions, it doesn't determine the policy about which drivers should be proactively assessed with respect to fitness to drive and how often. It also does not set policy around reporting requirements for health professionals and drivers. It's for the states and territory licensing and road safety legislation to set out these requirements, and these differ between jurisdictions. AFTD does summarise the various requirements to assist stakeholders in understanding the system and requirements for the various jurisdictions and programs. For example, Appendix 1 includes information about when and how often health assessments are required for various licence types, as well as for accreditation programs, including public passenger drivers, dangerous good drivers, and driving instructors. As I mentioned, these are determined by state and territory legislation and are not affected by the current project. This appendix currently does not include requirements for heavy vehicle accreditation programs, but this might change in the future. Appendix 3 summarises the reporting requirements, such as driver and health professional reporting obligations. Again, these are determined by state and territory legislation, not by AFTD. And I want to emphasise that these requirements vary between jurisdictions and aren't affected by this current project. I hope that sets some important context around the relationship between licensing, accreditation, and its impact on AFTD. Although we're not proposing any changes to the frequency and timing of health assessments for licensing, I thought I'd include this table to highlight the varied approaches to licensing of heavy vehicles across Australia. As you can see, ACT is the only jurisdiction that has prescribed initial and periodic health assessments for heavy vehicle licence holders. These are 5-yearly for MR licence holders and above. This has been a recent change, and there's further information in the paper about this. South Australia, New South Wales, Queensland and WA have annual age-based assessments for all driver classes, commencing at 70 for South Australia, 75 for New South Wales and Queensland, and 80 for Western Australia. These assessments apply across all licence types, including heavy vehicle licence holders. There are some specific requirements in some states to target high-risk drivers. For example, New South Wales requires health assessments only for drivers of MC vehicles. They are required on initial application and then periodically dependent on age. Tasmania requires assessment at initial application only for MC, and ongoing assessments aren't required for these drivers. In all states and territories, more frequent assessments are required if there is a medical condition that may impact fitness to drive as per the AFTD standards. This table explains the health assessment requirements for various public passenger accreditation and heavy vehicle accreditation schemes. The timing and frequencies vary, but the health assessments and medical criteria are all based on AFTD. The changes being proposed under this project will impact these drivers. However, already having regular health assessments, it's unlikely to impose a significant burden, although the management of drivers found to be at risk will be an important consideration, and we'll be exploring this during consultation. What we'll need to consider is how to improve screening approaches fitting into these schedules that require frequent health assessments, such as annually for the NHVS participants that are aged 50 and older. The costs and benefits will be discussed later in the slides. This slide includes some key information on the heavy vehicle industry. It's important to note that LR drivers are not assessed according to the commercial vehicle standards unless they fall under an accreditation program, such as a public passenger vehicle. In 2024, there were over 2.2 million licensed heavy vehicle drivers in Australia, with truck driving being one of the most common occupations among Australian males. However, only about 10% of these represent professional truck and bus drivers. As of May 2024, there were over 180,000 truck drivers with a median age of 47 years, compared with 39 years for other occupations. There were over 37,000 bus and coach drivers with a median age of 58 years. These statistics show that the heavy vehicle industry is an ageing industry that is also heavily male-dominated. We know that increased age and male gender can increase the likelihood of some medical conditions, including cardiovascular disease, sleep apnea, and diabetes. This slide includes some key information on road safety data from 2023 to 2024, broken into deaths and injuries. To many of you on the call, these figures represent more than just numbers on a slide and might represent something very personal, including loss of or injury of colleagues, friends, or family. During this period, 176 people died in crashes involving heavy trucks and 15 involving crashes with buses. Fatal crashes involving heavy trucks and buses cost the economy about $980 million per year. About 500 truck occupants are hospitalised from road crashes annually, as well as 250 bus occupants. Of the heavy truck occupants, 30% are categorised with high threat to life injuries. There's limited information to attribute these crashes and outcomes to medical causes. However, we do know that medical conditions can increase crash risk, so medical management is among several interventions to address safety on the road for heavy vehicle and commercial vehicle drivers more broadly. Now looking at the broader commercial vehicle industry, it's quite diverse and includes around 419,000 accredited drivers, although this may include an overlap as drivers may be enrolled across multiple schemes. Over 100,000 taxi and rideshare drivers, over 26,000 dangerous goods drivers, 3,149 BFM operators in the NHVAS, 101 AFM operators in the NHVAS, 183 truck safe operators, and 5,034 Western Australian Heavy Vehicle Accreditation Scheme operators. So it's well established that compared with the general population, heavy vehicle drivers, including truck and bus drivers, are at a higher risk of a raft of health issues, including heart disease, diabetes, sleep disorders, poor mental health, poor musculoskeletal health, and drug and alcohol use. The Monash University Driving Health Study included surveys and phone interviews with over 2,000 truck drivers. It included self-reported data along with workers' compensation data. At a high level, the study indicates that 5.3% said they had cardiovascular disease. Research suggests that cardiovascular disease is the most common cause of death of drivers. Cardiovascular disease accounted for 26.67% of death benefit claims for male members of the Transport Workers Union between 2004 and 2017. 8.2% reported having diabetes and 13.4% reported diagnosed sleep apnea. Over 80% of truck drivers were overweight or obese, which is higher than the Australian average for males. 25.8% reported having high blood pressure. We also know that diabetes is linked to other health conditions such as type 2 diabetes, high blood pressure, stroke, and sleep disorders, which are the focus of our project. Based on our research, we recognise that these self-reported rates are below those in the general community, pointing to potential benefits of improved screening. It's also interesting to note that almost a third of drivers had 3 or more diagnosed medical conditions, which is 4 times greater than the Australian average. Research has suggested that having 3 or more chronic conditions nearly doubles the odds of experiencing a crash. This statistic is particularly concerning from a road safety point of view and highlights why we're taking a holistic approach and considering these 3 conditions in the project. You can review some of the other studies in more detail in the discussion paper chapters. We're interested to hear from industry stakeholders, whether you're aware of any other studies that you could point us to help us better understand priority areas and risks for commercial vehicle drivers. I'll now hand over to Fiona to take you through the current state of screening for the 3 conditions.
Thanks, Josie, and welcome everyone. And hopefully this material that I'm going through now, which is more around the medical matters, will help you understand what we have in mind. So, as Josie has explained, our focus is on the 3 high-risk conditions identified by the Transport Ministers. And these are conditions that appear to be more common among heavy vehicle and other commercial vehicle drivers. The discussion paper acknowledges that there are a broader range of health issues affecting commercial vehicle drivers, but in the first instance, we've focused on identifying screening options for these 3 conditions. In considering the approach to screening, we've also been mindful of the overlap of these conditions and their common risk factors, which is shown in this slide. So this shows risk factors across cardiovascular disease, diabetes, and obstructive sleep apnea, which are identified in the screening tools that I'll discuss during my presentation. And as Josie noted earlier, being male and an older age increases the risk of all three of these conditions. High blood pressure is also a common risk factor, which appears to be more prevalent in commercial vehicle drivers. So while we're presenting screening approaches for these individual conditions, it's our intention that the guidance will take into account these overlaps and the need to integrate medical information to guide the approach to overall risk management for drivers. The goal of introducing screening is to enable early identification and management of these conditions and respective risk factors, thus reducing road safety risks as well as improving commercial vehicle driver health outcomes and career longevity. So before we launch into that, I thought it might be helpful to have to differentiate between risk screening and diagnostic screening, because these can be a bit confusing, particularly if you're a layperson. And so this diagram tries to explain that. With the risk screening assesses risk factors to establish a person's risk of developing a condition as distinct from whether they have the condition. So for example, a person found to have a high risk of cardiovascular disease due to risk factors such as high blood lipids or high blood pressure, they can be treated to reduce these risk factors and thus reduce their risk of establishing heart disease in the future. Risk screening can also facilitate early diagnosis. For example, investigation of a person found to be at high risk of diabetes may result in a diagnosis of diabetes following a blood test. So this means the person commences treatment earlier than they might have done if they'd waited for symptoms to develop. And if they don't have diabetes, the focus will be on modifying and treating their risk factors and repeating blood tests in the future to see if diabetes becomes established. So risk screening is a way of economically reducing the impacts of common medical conditions without applying expensive and often invasive diagnostic tests to everyone. And in line with this approach, our project focuses on improving risk screening to enable early management of risk and early management of conditions if they're identified. So I'll now run through each of the three conditions in terms of what is currently offered in terms of screening, both in the population and in assessing fitness to drive in other jurisdictions. And this slide summarises the points that I'll make in those areas. So aligning with our overall goal, the goal of introducing cardiovascular risk screening is to enable early identification and management of cardiac risk for commercial vehicle drivers, although we do acknowledge that not all cardiac events can be predicted. This point has been strongly emphasised by our expert working group. And as Josie mentioned earlier, cardiovascular disease is the most common cause of death in commercial vehicle drivers. And whilst it is also the most common cause of death in the general population, the data that we've seen points to commercial vehicle drivers dying at a younger age. Cardiovascular disease is therefore the subject of population screening recommendations. So that's all of the population, and the Heart Foundation outlines these recommendations, and these are endorsed by the College of GPs. The latest recommendations for population screening were published in 2023 and recommended that Australians over 45 who do not have symptoms of cardiovascular disease and don't have known cardiovascular disease are screened using the cardiovascular disease risk calculator. The screening determines a person's risk of having a cardiovascular event such as a heart attack or a stroke in the next 5 years. So this screening can be done at a GP visit, and some of you may well have experienced that. And repeat screening depends on the outcome. So for example, if you're found to be at high risk, you will generally not be rescreened, as you'll be already under medical management for your risk factors. Those at intermediate risk will usually be rescreened every couple of years to keep track of their risk factors, and they'll be likely to receive treatment for those risk factors. Those at low risk are reassessed every 5 years. So you can see it's a graded response to follow-up depending on the risk. In terms of what's currently in AFTD, the standards don't prescribe cardiovascular risk screening. However, in the text, it's advised that it's good practice for health professionals to think about risk of cardiovascular risk for drivers, particularly commercial vehicle drivers. And they suggest that health professionals calculate the risk and manage accordingly. But obviously, AFTD does not have licensing criteria associated with those assessments. So in considering possible approaches to screening, the project team and the Cardiovascular Disease Working Group considered what was happening in other jurisdictions. And as you can see from this slide, sorry, I'm just adjusting where I'm up to. None of the other international jurisdictions include screening. However, in the US, there have been recommendations from expert groups to considering including it, but that hasn't eventuated as yet. The National Rail Standard is another source of reference for this group. And the Rail Standard has included predictive cardiovascular risk screening since it was first established in 2004, as following the waterfall inquiry. Sorry. And the standard includes specific criteria for managing fitness for duty depending on the cardiovascular risk category. For example, train drivers, which are Category 1 workers, are categorised temporarily unfit for duty while being investigated by a cardiologist. Workers at intermediate risk are generally fit to continue their duties while they're being referred. So this next slide just provides a little bit more information about the cardiovascular risk calculator. And you can see there the risk factors that it covers and the categories. So a high risk group are those with 10% higher risk of having a cardiac event in the next 5 years, and low is less than 5%. It's quite a sophisticated tool, this risk assessment tool, and it considers a range of other factors that may lead the score to be raised or lowered depending on things like ethnicity, mental health, and family history. So in the consultation, we'll be exploring how this risk assessment might be applied in a more prescriptive way for commercial vehicle drivers, and what might be the implications for drivers, licensing authorities, and health professionals. So let's move on to diabetes. And again, this slide takes us through the problem, what's currently being done in AFTD, and what's happening in other jurisdictions. So for diabetes, the risk for road safety are largely due to the treatment of the condition. So treatment presents a risk of hypoglycemia, so low blood sugar, and a severe hypoglycemic event whilst driving, as you can imagine, can be catastrophic, resulting in confusion and loss of consciousness. So some people also develop lack of awareness of hypoglycemia, which is another particular risk for driving, where they don't experience warning symptoms and are therefore at risk of experiencing a severe hypoglycemic event. So it's important to note too, though, that untreated diabetes, which is associated with high blood glucose, can also impact cognitive function and can affect safety. Diabetes is also associated with cardiovascular disease and with sleep disorders, as we've already discussed. So that's a broader consideration for risk and integrating that information. A key consideration for diabetes, as Josie has alluded to, is there's a significant rate of undiagnosed disease. And in fact, it's estimated that 3 in 10 of Australians with diabetes are undiagnosed. This has implications for hypoglycemic effects, but also for end organ effects. So long-term diabetes affects things like your vision and the feeling in your extremities. Again, risks for driving. And the prevalence of overweight and obesity points to this being a further issue in commercial vehicle drivers. In terms of population screening, this is focused on screening for diabetes risk, as we talked about earlier, rather than diagnosis of disease. So the risk assessment is designed to identify people who may be at risk and monitor them closely with follow-up blood testing. And the College of GPs recommends 3 yearly screening for diabetes risk and then 3 yearly blood tests for those found to be at high risk. Screening for diabetes risk and diabetes is not a feature of assessing fitness to drive currently. Diabetes is identified by self-report, and for commercial drivers, that's in the commercial driver questionnaire. So this approach does not capture the group who have diabetes but are unaware of it, and it does not assess diabetes risk. In benchmarking against international jurisdictions, we found that screening for diabetes is not undertaken in any of those jurisdictions we looked at. All of these jurisdictions rely on self-report of diabetes by drivers, and none undertake risk screening. On the other hand, our national rail standard does include active screening as well as self-report in the questionnaire. For Category 1 workers, so train drivers, they have a blood test for diabetes, and that also feeds into the calculation of their cardiovascular risk score. Category 2 workers who don't do cardiovascular risk assessments, they have a urine screen to detect diabetes. And the outcome, as I've said, is taps into the cardiovascular screen, but also the sleep apnea screening. So based on these findings, the options for this project have been to put forward risk screening and diagnostic screening, and these options we would like to explore in the further consultation with stakeholders. So this next slide just shows you the diabetes risk tool. This is available on the internet, and you may well have completed it with your GP at some point. And this tool assesses the risk of type 2 diabetes, which is the type that tends to develop in middle age, as distinct from type 1 diabetes, which develops in younger people. And the score predicts the risk of developing diabetes in the next 5 years. Those found to be at high risk with a score of 12 or more are usually screened 3 yearly for diabetes using a blood test. So if clinical screening were to be adopted as well as or instead of risk screening, it would be expected to reflect the approach in the rail standard, which you can have a look at in the discussion paper. And this is based on the current clinical guidelines for interpreting HbA1c developed by the Diabetes Society. So there's more detail in the discussion of paper about the technical aspects of that screening. So let's look at sleep disorders. And these are an issue of particular concern in the transport industry and have, as Josie said, been a driver for this project based on the coroner's inquest in the ACT. The interface with fatigue management is also an important consideration. And as you know, the health assessment requirements under the National Heavy Vehicle Accreditation specifically identify the need to focus on sleep disorders in health assessments conducted for drivers. Like diabetes, it's likely that these conditions are underdiagnosed and in the broader community, both in the broader community as well as in commercial vehicle drivers. As Josie mentioned, the Monash Driving Health Study found 13.4% of drivers self-reported a diagnosis of OSA or obstructive sleep apnea. But evidence that we've looked at shows the prevalence in the community is substantially higher, with a recent study in Australia of 45 to 65-year-olds found 40% of males had clinically significant OSA. Again, the prevalence of overweight and obesity is a potentially key issue in this group and a major risk factor for sleep apnea. So in terms of current population screening, neither the College of GPs or the Sleep Association recommend routine screening of the population for obstructive sleep apnea if there's in asymptomatic people, but they do acknowledge the risk to driving and make a general reference that assessment of people who are suspected of having OSA or suspected of having excess daytime sleepiness, that they're investigated for OSA. And as for cardiovascular risk disease, AFTD does not currently prescribe screening for particular screening tools for assessing risk of OSA or for other sleep disorders. The Epworth Sleepiness Scale, which assesses excess daytime sleepiness, is included, referred to in the AFTD chapter and is included in the Ostrodes form, so it is likely to be applied. However, the risk assessment tools, which include the Stop Bang questionnaire, which we'll look at, is not prescribed and are not included in the form. So we acknowledge that there are some inconsistencies there and scope for improving guidance for health professionals and more clearly defining what might make up an appropriate assessment for sleep disorders. In terms of the other jurisdictions that we looked at, the US has considered the issue of screening on several occasions with advice from sleep specialists, but has not progressed regulatory change at this stage. In Canada, they've been more proactive and assessment under the Canadian Council of Motor Transport Administrators requires screening for symptoms of OSA as well as risk factors and other conditions associated with the disease. They don't prescribe an assessment tool, but the symptoms and risk factors are featured in line with commonly used tools. And the UK doesn't prescribe assessment of sleep disorder risk. Again, the rail standard in the latest edition, a great deal of effort was devoted to that particular chapter, flowing from recent evidence that untreated sleep disorders impact on rail safety. And that chapter is now very comprehensive in its outlining of a prescribed approach to risk screening, combined with the Epworth Sleepiness Scale to assess existing daytime sleepiness. It also goes into considerable detail around what other risk factors health professionals should look out for and how they should progress investigation of a person found at risk. So this is a very comprehensive approach. It aims to ensure consistent management of workers, and the new content it also guides newly diagnosed management and demonstrates how quickly sleep disorders such as OSA can be managed and controlled, and people can be back at work within a matter of weeks with appropriate treatment. So this next slide, again, this is an example of one of the risk assessment tools. The Stop Bang is used in the rail standard. And in rail, the cutoff score is 3, and that prompts a referral to a sleep study to determine if the person has a sleep disorder. And you can see from this example that a person who is obese, male and over 50 will score 3, and this will likely be common among commercial vehicle drivers given the data we have presented to you. The working group has not determined a cutoff, and there's many considerations in terms of the potential impact on drivers and the industry and the health system. And we're gaining, exploring feedback from health professionals as well as the industry about those impacts. It's important to note that this is a risk assessment tool and does not diagnose sleep apnea. So a person with, for example, a score of 4 may be found on further assessment not to have OSA, and if that's the case, they will not have to undergo repeat sleep studies unless their risk changes. a driver won't have to keep fronting up to have a risk assessment with the same outcome and having repeat sleep studies. So back to Josie. I hope that provides a bit of an overview of what we have in mind.
Thank you. That was really helpful. Throughout we had many conversations with other organisations that are responsible for driver health or heavy vehicle safety initiatives. We turned that list into a table and have highlighted whether they're focused at a local or national level and what areas they target across behavioural change, technical, environmental or health screening. As you can see, there's a lot of great initiatives underway, but only 2 of these focus on health screening, being Healthy Heads in Trucks and Sheds, which is a national program, and the Open Road program, which is based in Tasmania. We recognise that the changes proposed in this project aren't a silver bullet to addressing driver health, and it will require ongoing collaboration with these current initiatives. As part of the consultation process, we're asking stakeholders whether there are any other initiatives that we're missing. We'll present a comprehensive final table to ministers, and we welcome your advice on whether there are other initiatives that you're aware of that should be included for completeness. So now we've gone through all the current state data, we'll now focus on the options proposed in the paper. As I mentioned at the beginning, the options represent a staged approach and go from option A of no change to option B, improving implementation of current AFTD guidance, to option 3, which includes 3 sub-options for screening for the 3 areas. So as option A is no change, we won't spend much time looking at this. We'll go on to option B, which includes improved implementation of current AFTD guidance for cardiac and sleep disorders. And this is achieved through building awareness and education with medical practitioners as well as drivers. As there's currently no screening for diabetes in AFTD, it won't include this. Option B also includes redeveloping the forms to include cardiovascular risk questions, and a sleep questionnaire like the Stop Bang, OSA 50 or Berlin questionnaire, as these are already referenced in the text and haven't been translated across to the forms. These updates could be considered interim measures and include things that could happen pretty quickly. Now on to option C. This builds upon option B and includes 3 sub-options to target the 3 areas. Option 1C relates to cardiac risk and proposes that AFTD be amended to prescribe cardiovascular disease risk assessment for commercial vehicle drivers, update guidance on assessing and managing cardiac risk for commercial vehicle drivers. So this would be new text that would be drafted with input from our cardiac working group members, include more detail on cardiovascular disease risk calculator, which was updated in 2023, and updating the forms, as I mentioned, as part of option B. Option 2C relates to diabetes and proposes that AFTD be amended to apply the OSD risk that Fiona just mentioned every 5 years, and in addition or in replacement of this, also require a routine non-fasting blood test for HbA1c every 5 years, plus the updated guidance for commercial vehicle drivers and updates to forms. Option 3C relates to sleep disorders and proposes that AFTD be amended to prescribe OSA risk assessment using include more comprehensive guidance for assessing risk, as well as testing, interpreting results and managing OSA and other sleep disorders, including the preferred questionnaire, as Fiona mentioned. I'd like to note that we haven't included details around thresholds, but we're keen to hear your views on this. And there were also some suggestions around including more content about fatigue management and the role of fatigue monitoring technology. So we're really keen to understand whether these 3 health risks are common in your workplace or industry and your views on how screening should happen. We're also interested to know if you're aware of what's worked in other industries or settings and any lessons we could learn there. We know that there's a fine line between introducing new screening and overburdening the driver and the health system. There'll also need to be consideration around how to operationalise any new screening requirements, and we'll now discuss some of the benefits, costs, and limitations. So the discussion paper includes further information on benefits, costs, and limitations, and I've included some high-level details on the slide here. We've included a disclaimer to state that the potential costs and benefits are more likely to be realised in jurisdictions and industries where there are periodic assessment requirements. So for option A, we've noted that there's no further benefits and that maintaining the current state may actually pose risks for the health of drivers when we have data to support the fact that the industry is at an increased risk of CVD, diabetes, and sleep disorders. In terms of benefits, it's likely that both options B and C will result in improved confidence, quality, and consistency in conducting health assessments, as doctors will have clearer forms to follow and new content with clinical considerations. The health benefits of early identification and management of risk factors and chronic conditions, including cardiac, diabetes, and sleep disorders, should also lead to improved road safety outcomes. In turn, due to these conditions being picked up early, it should reduce the ongoing impact on the health system. In terms of costs, we've highlighted the increased costs for implementation, including communication and education activities. There'll also be increased costs for drivers and employers for pathology testing, counselling, referral, and time off work for tests. If a driver is found to have a condition, there will be a cost imposed to manage their condition or other risk factors. There may be potential impacts on workforces while drivers are undergoing investigation and treatment. This might also impose a burden on the health system with an influx of referrals and tests. There will also be costs for driver licensing authorities to action system changes, as well as increasing the number of conditional licenses and reviews. There are many policy questions still to resolve around things like how periodic testing will work to ensure that drivers are only having the screening performed as part of the frequency outlined in AFTD. Would a medical review for a separate condition trigger the medical professional to screen for these 3 conditions? And there's also legacy issues that need to be considered around the relationship of an AFTD assessment and information being shared with the driver's local GP if they have one. So we're interested to hear your views on how things currently work and how you envisage the new screening tools working. We welcome written submissions on your thoughts on the costs, benefits, and limitations, plus anything that we've missed that you think we should consider as an alternative approach. Submissions can be made on the NTC website and will close on Friday, the 9th of May. We'll then review all submission material and prepare a consultation report and recommendations for consideration by Transport Ministers. We expect a decision later this year, which will inform our next review of AFTD. Please reach out if you'd like to discuss anything in the lead up to making your submission. My email address is here. We'll also post these slides and a recording of the webinar. So I think we've still got 10 or so minutes for questions. So if you've got anything you'd like to ask, please raise your hand and we'll give your microphone permissions to unmute. I'll just allow the mic.
Yeah, g'day, Josie. I've got a couple of queries. I'll pop one in the chat. The waiver requirement, I think it's 5 years, unless that's changed, because it links to the commercial vehicle driver fatigue code of practice, which has an extent out to 5 years. But if it's 3 years, I do need to know that.
I'll check. The WA team did review the content in the paper, so it should be correct. But there is also the interaction with the work health safety legislation in WA too. But yeah, I'll check that and get back to you.
And whilst putting screening to one side, I think one of the potential problems is that it might actually steer some of the workforce or potential workforce away if they know that they're going to have to go through regular screening in some areas. Now, there's a plus and a minus there. I get that, advantages and disadvantages, but might be worth noting that, you know, that available workforce pool might diminish somewhat too.
Thank you. Yeah, that's definitely been raised by our advisory group members, and yeah, something we're mindful of. But yeah, if you've got particular data and stats that you could provide us as part of your submission, we'd really welcome that as well to understand, you know, the true impacts of what these screening changes might introduce.
Thank you.
Thank you. Any other hands? No other questions? Okay, well, thanks everyone for your time today. I'll take that as that Fiona and I have provided very comprehensive overview of the discussion paper, hopefully saved you some time reading everything in detail. But yeah, really encourage you to put pen to paper and make a submission. If you'd like to set up a time to discuss anything with Fiona and I, please reach out. More than happy to meet offline. And yeah, thank you all again, and we'll give you back 9 minutes of your day. Thanks.